Hey everyone, this is Dr. Medicine RX and in today's video we'll be discussing about treponemal tests. This is the final video under investigations in syphilis. The video on non-treponemal test is up already, so do check it out if you haven't yet. So treponemal tests, they measure antibodies that are directed against Treponema pallidum in contrast to the non-treponemal tests that detect the antibodies that are formed against substances that are released following damage to the host cells. So these tests, they may remain reactive for life and are confirmatory tests that are performed after non-treponemal tests. However, they cannot differentiate between venereal and non-venereal treponemes. These tests are expensive and technically demanding. So we will be discussing all these tests under 9 subheadings. First off, we've got the Treponema pallidum immobilization test, the TPI test. In this, what we do is we take actively motile treponemes from testes of an infected rabbit. To this, we add the patient's serum. So obviously, the serum is going to have the antibodies that are formed against the treponemes. And following this, we also add the complement. So following an antigen-antibody reaction, there is going to be immobilization of the treponemes, and this immobilization, we are going to observe it under dark field microscope. This TPI test, it is highly specific, but it is expensive and it is not done nowadays. Next is the fluorescent treponemal antibody absorption test, the FDA-ABS test. In this, the antigen that we use is the Nicole strain of the treponemes, that is the Treponema pallidum subspecies pallidum. So in this, the serum of the patient, it is diluted 1:5 in sorbent. What sorbent does is that it removes any non-specific treponemal antibodies that are formed against non-specific treponemes such as the Reiter's treponemes, so that a false positive reaction does not occur. So on a glass slide, we take the antigen, that is the Nicole strain. To this, we add the patient's serum, and following this, we also add the fluorosin isothiocyanate labeled anti-human immunoglobulin. And if this binding has happened, then we'll get a fluorescence which we examine under a fluorescent microscope. So FDA-ABS test, it has max sensitivity and it has the most sensitivity in primary syphilis, but it does not indicate the disease activity. Next up is the Treponema pallidum heme agglutination TPHA test. Here the antigen is that of the ultrasonicated material from Nicole strain, which is adsorbed onto the surface of formalinized tanned sheep RBCs. The antibodies are those from the patient's sera diluted 1:5 in sorbent. And this serum, it is taken in microtiter plates or wells or even test tubes. And to this we add the antigen coated sheep RBCs, and agglutination of these RBCs occurs if specific anti-treponemal antibodies are present. The TPHA test is easier to perform than the FDA-ABS test. There are some modifications for the TPHA test. First is the microheme agglutination Treponema pallidum test. Here the test is performed in microtiter plates, and because it is performed in microtiter plates, the amount of antigen or antibody required is also going to be less. Therefore, this is cost effective. Then is the automated microheme agglutination assay, where the results are automated. And the third is the finger prick microheme agglutination Treponema pallidum test, which is done in children. Next is the Treponema pallidum passive particle agglutination test, the TPPA test. This is called as passive because the antigen is artificially coated onto inert carriers such as the gel particles. So the patient's serum is added to the gel particles which are coated with the antigen, and here again the agglutination occurs. If it is a smooth mat like agglutination, it is a positive test. If it is a compact button like agglutination, then it is a negative test. Next is the enzyme-linked immunosorbent assay, the ELISA test. This is useful for screening, and the antigens used here are going to be the recombinant proteins, especially the membrane proteins of treponemes such as TMPA protein, TMPB and TMPC proteins, and various molecular weight proteins such as 47 kDa, 15.5 kDa, 17 kDa and 44.5 kDa. The advantages of this procedure are that it can process large numbers of samples, and there is a reduction in manual error because the readings are going to be automated, and it is more useful in HIV syphilis co-infection. And the disadvantages are that it requires a longer time for processing, and also the price is going to be high. Next is the Western blot test. It also uses recombinant antigens such as the 47 kDa, 15.5 kDa, 17 kDa and 44.5 kDa proteins. These are there occurs an electrophoresis, after which these proteins, they are transferred onto nitrocellulose membrane, and the patient's serum is added, and the antigen antibody binding occurs, and it produces characteristic banding patterns, and this test, it is highly specific and sensitive for syphilis. Next are the IgM antibody tests. This antibody forms within 2 to 3 weeks of infection, therefore can be detected at that time, and the presence of this antibody indicates an active syphilitic infection. It is also useful for monitoring the therapy, and it is also useful in cases of congenital syphilis or reinfection or early primary syphilis or even neurosyphilis, because IgM antibodies do not cross placenta or the blood-brain barrier. Among the IgM antibody tests, we've got IgM FTA ABS test, 19S IgM FTA ABS test, IgM solid phase heme absorption test, and capita syphilis M test. Next are the enzyme immunoassays, which use enzyme linked immunoglobulins. These can detect IgG, IgM, or even both. Under this, we have the capita syphilis G IgG test, then Spirotech test, which has highest sensitivity of all the treponemal tests, and it is even recommended by the CDC as a confirmatory test. Then we also have certain rapid tests, which are point of care tests, and these are done in remote and hard to reach areas. Coming to the protocol of diagnosis, if a patient has clinical features that are suggestive of syphilis, then we do a non-treponemal test first, which is either a VDRL test or an RPR test. And if it is positive and if the titer is more than 1:16, then we go for treponemal test for confirmation, such as the enzyme immunoassay or the TPPA test. If both the non-treponemal and treponemal tests are negative, but the clinical features are highly suggestive of syphilis and the clinical suspicion is high, then we have to repeat the serology after 2 to 4 weeks. There is also a reverse testing protocol where first we go for the enzyme immunoassay, and if it is positive, then it indicates an infection. But since the treponemal test can stay positive for longer periods of time, it can indicate that it can be a past or a present infection. Therefore, there is a need for confirmation with a non-treponemal test such as the VDRL or the RPR test. And if it is positive and has high titer, then it indicates an active infection. But if it is negative and the enzyme immunoassay was positive in the first place, then there is a requirement to perform a second confirmatory treponemal test such as a TPPA test. And if it is positive, and the patient has no history of any treated syphilis, then it indicates an infection. Thank you. Subscribe for more.